Good Friday morning. It is October 1st. We are live inside the Dolph Simons Family Broadcast Studio. Welcome to the Morning Medical Update. Today we are tackling the most asked questions that we did not get to earlier in the week. So, of course, helping me out with that, doing all the heavy lifting, Chief Medical Officer Dr. Steve Stites, Dr. Hawkinson's over here as well. And we have Dr. Marc Parrish to answer more of your pregnancy questions. So thank you so much for being here. We're going to get to Dr. Hawkinson and find out what our numbers were like overnight. Good morning.
Yeah. Hi. Well, we're still holding steady, low 30s. We have 32 active infections with 8 in the ICU and 6 on the ventilator. 7 of those are vaccinated as well. Numbers are a little bit different there. We have 35 additional patients. So our total is 67. But again, of those 32 active infections, we should say that only 7 of those are vaccinated. So.
And none in the ICU are vaccinated, and
Correct.
none in the ventilator are vaccinated,
Correct.
which is the recurring strong story we have.
You're all fired up today. It's Friday.
I'm ready to go.
You've already worked out?
I've worked out this morning. I got up really early. I worked out. I'm a little hyper. I got my super cool Star Trek mug that is the Chief Medical Officer, Dr. Steve Stites, set on it, and that is from Dr. Hawkinson's parents, which is a pretty cool deal.
You're going to carry that with you. You got meetings
I'm
today.
pretty proud.
It's going
I'm
to be with
pretty
you.
proud. Yeah.
And it says Chief Medical Officer on it, so it cannot be
does.
disputed ever.
No,
Right.
and it says Dr. Steve Stites instead of Dr. Spock Stites, but that's the only other thing I could have done.
That's
differently.
right.
So we know that Bob and Tammy will not be taking that, and if they do,
They don't.
No.
And plus, it's got the
It's
blue
got your
shirt.
name.
It's got a blue shirt, so I'm not a red shirt.
Right.
That's important.
There's only one.
Live long and prosper. Blue shirts live longer than the red shirts.
What do you
Right.
do? Lift weights or do you run?
Yes.
What are you doing in there? We just want to know.
You know,
Take
so
us-
this morning I did a big workout. We had to do 3 minutes on the bike, and then 2 minutes on the bike, and in between you had to do wall balls and all this other stuff. And then, you know, wall balls you had to throw up. You had to do 100 wall balls, and that was a workout. It was tough.
Oh, I'm going to get some cell phone video of that.
Yeah, yeah, you bet you do.
You know,
No, you won't.
I told you, people want to know what's going on in your life outside
Okay.
of the studio, so we'll have to find out.
I'm a wild
he's
and
just
crazy
a
guy.
regular person.
Just
Yeah.
a regular guy.
physician.
That's
Yeah,
right.
That's what he was.
Well, it is a
4
Good
hours.
Friday, and we're so glad to have Dr. Marc Parrish with us because we know we have a lot of pregnancy questions. Of course, the CDC's emergency recommendations that came out. Dr. Stites, I know you have some questions for Dr.
I
Parrish.
do. I can't wait to grill him.
Go for it. It's, I'm
Okay,
gonna do-
so-
we're going to get to
So
those
what
reporter
do you
questions.
think about these emergency recommendations on pregnancy, and what's going on here?
You know, these don't surprise me at all. We were here just a couple of weeks ago, myself and Dr. Winnicke, and sounding the alarm already on the importance of getting the vaccination in pregnancy. It is no shock to me that CDC is now pushing the alarm button themselves because of what we're seeing in regard to the severity of disease processes that are affecting our pregnant moms and the number of deaths that are occurring both in moms and in babies. You know, I think a lot of this is reflected on the effect of the Delta variant. As we anecdotally discussed last time, we had not been observing as sick of moms, nor had we been hearing about maternal deaths at the rates that we had been experiencing until this Delta surge has started to occur. I would say part of the canary in the coal mine evidence that we had seen that this was coming comes from the Southeast and Louisiana, Mississippi, where they were seeing a lot of maternal deaths, increased rates of stillbirth. We're seeing that in our own patient population, probably not at the percentage or the rate that they're seeing down in the Southeast. But without a doubt, this is a concerning trend. And, you know, how do we stop that trend? We want to protect mom, protect baby. They protect themselves first by getting the vaccination. If you protect yourselves, mom, you're going to also protect your baby.
Yeah, it makes total sense. But, you know, the one thing I find frustrating is the FDA, you know, we've had this conversation already, but just to say, we're going to play it out loud for our listening audience.
Yeah.
The FDA, when they approved the Pfizer vaccine, said in the pregnancy category there's not enough evidence to say if it's safe or not. Now the CDC says you have to go run out and get the vaccine.
Right.
Okay, Mark, I'm
Yeah.
going to hold you personally responsible for changing the FDA labeling. Can you do
Right?
that?
Yes, I'd love to. That's definitely above my pay grade. But,
No, it's not anymore. Go.
But I, you know, I'd love to sit on that on the committee that makes those decisions. But you know, I definitely am sympathetic, or at least respect the concerns of those moms out there with the unknown of what does the vaccine do to my baby? What does the vaccine do to me during pregnancy? Fortunately, we have a lot more data now than what we had even 8 months ago. And that data is showing us that the vaccine is safe in pregnancy. There are no adverse pregnancy outcomes affiliated with taking the vaccine, no matter if it's in the preconceptual period. So for those moms that are trying to become pregnant, it does not affect your ability to become pregnant. It does not affect fertility. It does not affect an increased risk for miscarriages. And it does not increase risk for things like stillbirth or for preterm birth or for any other pregnancy-related complication that you can think of. On the other hand, the virus causes many of those things that I just listed off that I said the vaccine does not increase the risk for. The virus, the COVID-19 virus, does increase the risk for many of those adverse pregnancy outcomes.
So it's interesting because the CDC actually on their advisory, it was one of those things where they were pretty clear about this. They said, okay, so if you are pregnant, if you are trying to get pregnant, and even if you're thinking about trying to get pregnant, I mean, it was really, I think it said almost all three of those things. It said, go ahead and get the vaccine.
Yeah.
So they must really feel like it's important.
Yeah, absolutely. And I think that they're saying this, and they're really, again, they're sounding the alarm because of this newer data that we're observing. Twofold data. One is the increased number of pregnant patients and those that were, again, but becoming those that want to become pregnant, those that are pregnant, those that are lactating moms that have gotten the vaccine. They've not shown any adverse outcome there. But again, to kind of bolster that, alarm that the button that they're pushing is this information that's coming out about how the Delta variant of the COVID-19 virus is affecting our moms.
Yeah, what a big deal. So don't be a Star Trek redshirt. Get yourself a vaccination so you can survive this episode. Is that what we're saying?
Yeah, absolutely.
Awesome. Well, Hawkeye, this sounds like a really critical thing.
Yeah, absolutely. I mean, we've tried to say it. We just have to keep giving our message in different ways. Obviously, this stepped it up this week, and we really are just looking to protect, everybody, especially those new and soon-to-be moms, and especially baby, and really everybody in that household.
Yeah. Hey, you got to fix your collar up, buddy. It's all kind of wrinkly today.
Geez.
Sorry. Okay, Jen.
It's Friday.
Yeah.
He just blows in.
I wasn't going to wear a tie. Nobody else did.
Yeah, I know.
Wow, calling you
Didn't
out.
get the memo.
On air. I love it. Okay, we're doing that now.
We've been doing this for 2 years. Come on.
Okay.
And it's Friday.
It is Friday. Okay, so I want to move on to the next hot topic in the news right now, which is the Merck COVID-19 pill. It's said to prevent severe illness and hospitalization by 50%. Donna at Channel 9 has a question. She was referring to it, this magic pill that could treat COVID-19 once a person gets it. This is the first time she'd ever heard of that pill that could help. Would this just be another much needed tool in the toolbox to fight against COVID and keep people out of the hospitals? Tell us a little bit about this.
It's an important tool, but it's not the answer, right? The answer would be vaccinated so you don't get sick. And remember, it reduced rates by 50%, not 100%. It didn't eliminate a severe having to come into the hospital. Now, it is clearly an advance, and I wish we had Mario Castro here because he's talked about these pills before, and we've actually done some of the studies involving them. But Hawkeye, when I looked at the pill data, it was good.
Yep.
We don't have it yet. It's not been published. We've only got the company's reports.
Yep.
So that's good news. But the pill has to be taken early. It can't be taken later, and it doesn't help you once you're in the hospital. They did a study in patients who are hospitalized and gave them the pill. They found no improvement, so they stopped the study. This study got stopped early because the improvement was significant, and so they're going to take it directly to their to get their early use authorization.
Yeah, I mean, I think we're waiting for the EUA to come. It is interesting. It's good. But I also think, just like you said, with all of these therapeutics, not preventive measures, but therapeutics, so the monoclonal antibody, the remdesivir, really getting it earlier when you have symptoms is a lot better. The also caution that I would bring is that we've learned with other viral illnesses that resistance can develop to these. So I think if we do see resistance down the line, do not be surprised. We know that is prominent with HIV, and that's why we have to give you a cocktail of at least 3 active drugs for HIV. We know for other things such as hepatitis B, sometimes we also give you 2 different meds as well. So I think with antivirals, it's quite a bit different than antibacterial medicines, but this is hopefully one other way to keep people out of the hospital, to keep them from getting severe disease.
So it's taking one pill twice a day for 5 days. and then you're done. It does appear to reduce hospitalizations by 50%, which is great. It doesn't eliminate them. I believe in looking at the preliminary study data, there were no deaths in the treatment group. There were some deaths in the placebo group. So I think it's going to be effective therapy. It sounds like, and we just need to get it out there. They thought they could release around December, January. We'd start getting the pill out there. So I think that is a big win. What I don't want to do is see people say, okay, I can take the pill instead of taking a vaccination.
Right.
This is a lot like a Tamiflu and influenza vaccine. You don't really want to get influenza, and you don't want to spread it to everyone else, right? The other problem is that there's no clear indication yet whether or not this pill actually reduces the risk of spread to another person. So I think that's really an important thing for our audience to hear. What you want to know is whether or not that pill is going to reduce the risk of infectious spread. We don't know that yet.
So then, Dr. Parrish, that's my question is about for pregnant women who are concerned about getting the vaccine. If something like this were to be approved, is that something that you would want as a good backup, as a good option for someone who wasn't willing to get vaccinated while they're pregnant?
Yeah, absolutely. I think that we know that we use this term, so if mom's not doing well, baby's not going to do well. We say death is the ultimate teratogen being something that would harm a pregnancy. So if mom is not doing well, then baby's not going to potentially survive either. And so in these situations where we don't have a whole lot of data, it's optimal to have as much information as we can. Unfortunately, pregnant moms are oftentimes left off or excluded from being involved in trials that are looking at the effect of these medications, and probably in some senses, rightfully so. But if it is going to show that it will improve maternal outcome, if it helps mom, then we would absolutely condone the use of this in pregnancy, just like we do right now with the monoclonal antibody. We know that that's safe for use in pregnancy. So those pregnant moms that are showing milder disease that aren't requiring hospitalization, our pregnant moms, we're encouraging them to go get the monoclonal antibody.
But we don't know the safety profile of this new
Correct.
therapy in moms yet. It wasn't talked about. And so, Hawkeye, I think, once again, vaccination is the real answer, just as it is with any kind of pandemic or severe flu epidemic or anything else. The pill is there for rescue therapy, essentially. So if you start getting sick, you take the pill.
Yeah, I think the thing to think about the pill as well. So we don't want to compare it to influenza or Tamiflu, but we're going to make this right here, that comparison right now. Even with Tamiflu, your reduction in symptoms is by like a day or day and a half, truly, if you get Tamiflu. So again, different viruses, different infections, different therapeutics, but if we are drawing any comparisons. And I think once you get out into post-marketing analysis and things like that, you really have to see what the benefit is. It certainly looks good now, but just also remember all the caveats that do come along with antiviral medicine, oral antiviral medicine, this infection in general, and overall there is nothing that substitutes for the preventive measures, the non-pharmaceutical interventions in those high-risk situations, and especially vaccination.
And to say as well that again, we have to make sure the supply is not limited, because they say they'll be able to have 1.7 million doses around January the 7th, and they're going to distribute it worldwide, especially to countries where there is not as much vaccination to help reduce the burden of the disease. So those are good things by Merck, and we'll just see how it plays out once the evidence is fully reviewed. I also want to call out attention that a new monoclonal antibody combination was studied and was published yesterday in the New England Journal of Medicine. That looked good. Reduced hospitalizations by 70%. That's a big number. Reduced viral shedding by a log, and reduced the length of time you're sick significantly. And that's an outpatient infusion, again, of a combination therapy by Regeneron. And so I think that also looks pretty darn hopeful. I think the monoclonal antibody infusions don't get enough discussion. They probably don't get used enough. They are incredibly successful. They really do help reduce severe hospitalization and death, especially in people who have high-risk categories. This is one more tool to show that that's true. And both the new monoclonal antibody study that was published and this pill both claim good efficacy against the Delta variant. So I think, again, we need to see more of the data. The monoclonal antibody therapy is published in journals. We got plenty of there. We got lots of data on that, and that's available. So the pill will want to see what the data looks like. But both of these are great advances in the fight against COVID-19, I think, Hawk, don't you?
Yeah, I mean, I think we need everything. The prevention, the treatment. Again, a lot of these treatments, the earlier the better. So if you develop symptoms, don't wait a week to go get tested or anything like that. If you know you've been exposed, go get tested. The earlier you get any of these treatments, the better off they will have benefit. So the quicker they will have benefit.
I think we have a reporter on the line. Go ahead with your question. No reporter on the line. Okay, I do have one more question from Channel 9. Some news out of Dancing with the Stars. I know you've been keeping up on that.
You know, listen, my wife and my mother-in-law love Dancing with the Stars, and so I sometimes watch it too.
Okay.
Of course, I'm just a peripheral. I'm not really watching it.
Whatever.
But I do watch it.
Yes, you do.
Okay,
so
I'm
a
such a great
contestant
dancer.
on Dancing with the Stars has tested positive for COVID-19. Cody Rigsby says he is vaccinated and that this is his second COVID infection this year. How rare is that, is what the first question. He says that he had mild symptoms and that when he had it earlier this year, before he was vaccinated, symptoms were much more severe. Is this evidence that breakthrough infections are typically less severe? So how rare is it to have that second infection, and then are second infections with a breakthrough less severe?
Yeah, so a couple thoughts about that. So, and Hawk's weigh in. So first of all, an N of 1 isn't really much of a study.
Yeah.
This is just one person's story.
Okay.
But it is consistent with the data that if you've been vaccinated, if you do get COVID-19 again, it's harder to get, but you can still get it. We've been saying that all along, so that is not a surprise. And second of all, he's had it twice, so he's probably got some at-risk behaviors he needs to clean up a little bit. Let's just be bluntly honest. If you get it twice, it means you're probably not doing the right thing around masking and distancing and all those other things. And third, it means that the vaccine did its job, right? Because he wasn't as sick this time around, and it wasn't as severe. So we would have to say, once again, vaccination works off.
Yeah, no, I think that says it perfectly.
Okay, so we've got some great questions coming in right now, but we're going to get to some of our follow-up questions from our community. Several scientists have said that they believe Delta will be our last bad surge. What do our docs think about that?
I don't know how we can predict that. I think with what we've seen with this pandemic so far, with what we know about viruses in general, what we know about this virus is, mutations and substitutions do occur. We will see differences. But why? But a lot of this is also behavior related. And we know that there is still a large proportion of the population that is unvaccinated. So getting these people who are eligible vaccinated, getting them vaccinated, and then hopefully once the younger children are able to be vaccinated, getting them vaccinated. But it doesn't just stop in the United States. Again, this is a pandemic. We know that there are just large areas and groups of people who are still unable to be vaccinated, and we need to get everybody vaccinated. So I'm not really sure that this will be the last surge. I don't have a lot of optimism that it will be, but we will be ready, and we will always be looking and prepared if we do continue to see new surges or new rise in cases. But again, a lot of this is also related to behavior.
Yeah, I think that's exactly right. And the answer is, as long as people are masked and following good safety guidelines, then we'll be able to keep the surge at bay. I think this new oral pill will help us. I think the monoclonal antibodies will help us. I think vaccination helps us. But the most important thing is what you do as a citizen and how well you live your life. And I have a sneaking suspicion it's not the last surge we're going to see, because we still have half of our population in our area that has not been vaccinated. And so I think my fear is what's going to occur is the weather gets colder, just like it did last year, and people start taking off their masks because this surge is starting to fade. That's great news. But then, a lot of pressure to not wear masks in schools, not wear masks inside, and people start taking their masks off, and we still only have half the population vaccinated. Now, then I would expect another surge. What I hope is that with these other pills, these other antibodies, and other things, we'll do better. And with a few more people vaccinated, we'll do better. And then maybe we'll get back to masking quicker. And lastly, there may be enough people that have held the Delta variant, the next surge won't be as bad unless it's a whole new variant. And so do I really think this is the last surge? No. I what Hawk said.
So Janet says she may have missed your answer on this, but can you take the antiviral with monoclonal infusions?
I don't think we know the answer to that question yet, Hawkeye, but I would expect you could.
Again, the company is right now only applying for the EUA, so I think there's a lot of questions that are unanswered at this point in time. We know that if you get monoclonal antibodies, for the most part, you're going to be protected from coming into the hospital. and having severe disease. But if you happen to be that small percentage of people that still do progress, and you're within the time frame of coming into the hospital and having those symptoms, you can still get remdesivir therapy. But I think that question is unanswered, and I don't know that until it comes out that there will be any guidance on that.
Interestingly too, the study commented that even if you had antibodies, serum antibodies, which assuming you either had COVID or you had a vaccination, you still benefited from getting the infusion. So that was interesting.
Yeah.
So we'll look at that.
And I would right now I would say that if you do get it and you're early in that phase, I think we have really good data with the monoclonal antibodies that they seem like they may be more efficient and beneficial. But there is access issues with that and the time, and so they're just different medicines, and you have to take every individual person as an individual and then assess their risks on what they'll be able to do.
Dr. Parrish, Carol says, what if a pregnant woman has high COVID antibodies after having COVID? Are you still recommending they get the shot?
So the answer is yes, and I would defer to Dr. Hawkinson because I can't recall is it 3 months after or 6 months what they're recommending?
Yeah, so again, whether you're pregnant or not, whether you're hoping to be pregnant or not, whether you're a man or a woman, if you've had COVID-19 in the past, it is still recommended that you get vaccination. There is no minimum time between having the infection and getting vaccinated. So really after that 10 days of isolation that you should be home out of the public, you can go get vaccinated. Why is that? We are seeing more and more data suggesting that when you do get vaccinated, your antibody levels are elevated. We know, but that is not the whole story. The more important thing is that you create a wider breadth of immune response, of B cell and T cell response, so that you can continue to develop new antibodies to variants of concern, the ones that we know of and the ones that we don't. The same thing is being said for T cells as well. And so I would also caution this question, the asker, that I don't think we know what antibody levels mean, especially if you're getting it from a commercial lab. There's really no correlation with a certain antibody number that you may see on that result and the amount of protection you had. So the answer to the question is yes, even if you've had COVID-19, you really need to go get the vaccination, mostly because this will continue to expand and promote your current immune response and also help for future variants and anything that may come.
So because I'm non-clinical, I have to ask this question because we get this every day about the antibodies. But if we're saying that the vaccine is more effective than just the natural antibodies, then why are people so hung up on the antibodies?
Yeah, I think this is the whole problem really with the stem of this question.
Yep.
We don't know how high we don't really know the full correlation between antibodies and whether or not you're going to get really sick from COVID-19. Because there's so many different kinds of immunity, but people only talk about the antibodies, and there's probably 5 other layers of immunity that we can even describe well, and maybe many more than beyond that, but at least 5 others after that. And so I think the struggle is, while there is some early evidence that suggests the higher your antibody level, the better you do, there's also evidence that suggests that if you get too many antibodies, you can actually do worse. And so it's all very goofy, it's all very murky, and what I would say to folks is this. Look, you can have antibodies, that's a good thing, but it doesn't really guarantee you against severe illness and death. Yeah. Vaccination is a 99% guarantee against severe illness and death. So you can either hope you're right about antibodies, which we really don't know yet, and you're just kind of, even the good people who study this for their full science don't know this, or you can go get vaccination, in which the evidence is overwhelmingly clear that it is not a dangerous thing. The vaccination is safe, and you will have a 99% reduction in severe hospitalization and death. So I think that's the answer right there.
Yeah. And I think the other thing to look at is, in any random lab or company that has an antibody test, you don't really understand what that antibody is really for. Is it a neutralizing antibody, or is it just an antibody that is otherwise binding to spike protein? The other thing is it an antibody against spike protein, or is it an antibody to N protein? So I think those are important things to really consider, and I don't think you should draw your immunity based on getting antibody tested. There is no guidance for that. There's really nothing to support that in the general population. So I think if you've had the infection, please go get the vaccination. If you're otherwise not immunosuppressed and you've had your 2 doses of mRNA vaccine or Johnson & Johnson vaccine, you can really take comfort in that you're mostly going to be pretty well protected.
Okay, I think you just answered that question that I was just going to ask. So I'm going to go on to this question. If I have complications from childhood vaccinations like seizures, can I expect the same from the COVID vaccine?
No, simple answer is no. Again, there's really no major contraindications to getting the COVID-19 vaccines, even with reactions to previous vaccines. If it was seizures as a child, I would really kind of want to get full details of that and certain things. Obviously you are an individual, you need to talk with your individual medical care team, but there is nothing in the guidance that suggests that there are issues with the COVID vaccine if you've had reactions to other vaccines, unless you've had specific reactions to the components of any of these vaccines.
I've heard if you have severe reaction to the shot, it means that you have a strong immune system and it's trying to fight back. If you have no effects from the shot, it means you have a weaker immune system, and those are the people who really need the booster. Any truth to that?
Yeah, I don't think we know the answer to this question. Yeah. We've got a lot of people who don't have a huge reaction to the shot and they do just great. And so we've seen people who've had this big reaction to the shot and they didn't do great. There's so much at play here in this question. And there's so much to our immune system that while it feels like a good interpretation, I can understand there's this intuitive logic that you want to believe that. In which case, I had a terrible reaction to that booster. Therefore, I should be safe forever. But I don't really believe that that's true, Hawkeye. And I think we just don't know.
I don't believe there's any correlation to both post-vaccination reaction, either locally or systemically, and you shouldn't draw your immune status based on that.
Okay, so if a person is recovering from COVID, Dr. Stites, from COVID pneumonia, is it most likely there will be some sort of lung damage?
Yeah, that's a great question. And again, there's no clear answer to that. I will say this. If you have been on the ventilator, if you've been in the hospital, you have a lot of scar tissue in your lung as a result of that COVID-19 infection, that's more likely to be permanent. But there can be other things that resolve after COVID pneumonia. There's a lot of fluid in your lungs. There's inflammation in your lungs. Those things can get better, and not everybody who has had COVID-19 has a significant scar. So it really depends on how much scarring it is, and unfortunately, severity doesn't necessarily correlate with that. Having said all that, if you get so sick that you need to be in the ICU and you're on a ventilator, there's a likelihood that is increased that you're going to have severe scarring. But there's a lot of reasons patients can have to end up on a ventilator or be in the ICU with COVID-19. And scarring is only one of the reasons. There are other things that play as well. And so it's one of those questions where there's probably a trend in that direction, but there's a lot of factors in play, and we can't say that absolutely.
Okay, any news on the Moderna booster shot?
I think you're probably as on top of it as we are. We look at it all the time. What we know, last week the New England Journal published an article in which the level of protection at 5.2 or 5.5 months after you had your initial inoculation with the Moderna vaccine was still remarkably high, higher than the others. And that may be true either because there's a higher dose or because of a longer interval, 3 versus 4 weeks for the Pfizer vaccine. That's true. So it looks like at 5.3 months there's no need for a booster. What that means at 8, 10, 12 months, we don't know yet. We'll just have to follow the information, and I think that's what the FDA is doing. So I don't think there is any clear news. We heard Fauci say yesterday or 2 days ago that there all these drugs are going to need boosters at some point, and I think that's true. I just think it's a question of interval, number one, and then number two, is every drug going to have its own interval, or is there going to be a standard interval? Which is, I don't think we know the answer to that yet. And the reason to do a standard interval is that there's no confusion. But I don't know which way they're going to go.
Yeah,
what do you think?
I think there's there are a lot of details in this. Number one, if you did get Moderna or Pfizer or Johnson & Johnson, just take comfort in that you are still very well protected from going to the hospital, having severe disease, and dying. The other thing is, I think a lot of the issue with Moderna is there's not as much real-world data compared to Pfizer, who had that whole country, Israel, also. But we also know that some of the trials were a little bit behind on Pfizer. So I think we're waiting for the actual trial data, as well as more real-world data. The other thing is, what are we getting booster vaccination for? Obviously, for if you are over 70 or 75, it can protect you further or more if you get that booster compared to if you are under 70 or 75. We've seen that. But also, do we think that there is going to be more significant increase in reducing transmission if you get that booster, at least for the short period of time? And I know Dr. Fauci had mentioned that. There's some data behind that as well. So that's the other issue. I think we are, and certainly I am expecting that everything will be, for the mRNA vaccines, really be the same across the board. Maybe, obviously not during that first and second dose where there are 3 weeks versus 4 weeks, but I think everything will eventually be the same because we know the messaging has been so confusing already. So I think they will do that to standardize it. I could be wrong, and that's just my opinion. And then for J&J, we will probably expect another dose. But, moving forward, certainly I think it's reasonable to think that overall 3 doses will be, at this point, at some point in time, will be considered maybe full vaccination, whether you're immunosuppressed or not. We just have to wait and see. Obviously, the only thing we have information about right now is Pfizer, but I do expect Moderna and Johnson & Johnson messaging to come probably within the next few weeks.
Would you recommend a third Pfizer shot for a pregnant woman with gestational diabetes?
So at this time, the CDC does not include pregnant moms on that list of people that would be eligible for the booster shot that are in a higher risk category. While these moms who are pregnant are immunocompromised and theoretically at higher risk, we do know that they are very well protected if they have received the appropriate regimen of vaccination, whatever that may have been, Moderna, Pfizer, or the J&J. With gestational diabetes, that does not necessarily make them a significantly higher risk. So if they've had the appropriate regimen of vaccine to this point, they're very well protected and should rest assured that both mom and baby will be fine.
Good to know. All right, Melissa, these are some questions coming in today, so thanks for sending those in. Wants to know, Dr. Stites, is there a difference between COVID pneumonia lungs and just regular pneumonia lungs if you were looking at it on an X-ray? Would it look different?
Well, so chest X-ray is a very blunt tool. Okay, so if we don't think, what's the X-ray show? But the reality is, X-ray technology has moved a little in the last 50 years, but not that much. And so it's hard to look at a chest X-ray and know the difference between I've got pneumococcal pneumonia, I got staphylococcal pneumonia, I got influenza pneumonia, I got pulmonary edema, I got, there's a lot of different things that can cause a funny infiltrate on film. Now, there are some characteristics of COVID pneumonia that look a little similar, but they can also look similar to other things. So I would hesitate to use a chest X-ray to distinguish the level of severity or the type of pneumonia you have. I think that's actually really hard. And I think even prior to COVID, it was really hard. And COVID isn't really that distinctive on an X-ray appearance to help you know that. It's more the clinical setting, the diagnosis you use, looking for other things that may have caused the same problem that help us understand that.
Craig wants to know, if someone is admitted to the hospital with COVID, can they say that they don't want a certain medication and then ask for a different medication?
That's very tricky. Here's the answer. If somebody comes in and asks us for Ivermectin, we're not going to prescribe it because it's not effective therapy, and we are under no obligation to offer you therapy that's not effective, and that could be harmful to you. So you can, in fact, for example, I take care of cystic fibrosis patients, right? These CF patients are admitted oftentimes 5 or 6 times a year. And they'll come in and they say, hey, I don't want that antibiotic because it makes me feel crummy. I want this antibiotic. And you know what? We work together to come up with that solution. But that patient's incredibly well informed by the course. They're hospitalized a lot for pneumonia. We have to treat them a lot for that their cystic fibrosis exacerbation. So we work together in choosing those drugs. I have no problem doing that. But they're not asking for Ivermectin either. And if they did, we'd say no. And I think the same thing may be true. The problem in COVID-19 is that you're not talking about a patient population who's come in 5 or 6 times a year and is super, knows how that drug works in their body and has had a lot of different experiences around that antibiotic. So, do physicians work with patients to help choose therapy? All the time, no problem. Yeah. Does that mean we have to choose ineffective therapy? Absolutely not, and we won't do it.
Yeah, and I agree with you. I think, cystic fibrosis is a very special population. We do understand that for a lot of bacterial infections, there are options too. Yeah. Maybe less so for cystic fibrosis patients because they are seen just so much, as you had stated. Certainly less for antivirals, certainly less for COVID-19. And again, we are supportive of using ivermectin in a clinical trial. There are 2 clinical trials that are going on right now. However, if you are to that stage where you are coming into the hospital, most likely you are past that viral stage, and that is really where it is thought that ivermectin has any use whatsoever anyways. In those first few days, just like we talked about early on in the show, monoclonal antibody is best when you use it early. Any of these new, the oral pill or the remdesivir, all of those are best used early on in the course of disease anyways. So I think the antibacterials are quite different than the antivirals.
I agree. And I think, again, these COVID patients haven't come in 6 times in the last year.
Yeah.
They haven't been tried all the different drugs. Oh, wait, there's not very many drugs to choose from. So it's a totally different thing. But the point I want to make is that we as physicians work with our patients all the time and talking about the benefits and outcomes of different treatments. So we would absolutely do that because that's what we do. You can turn down remdesivir as a patient. We're not going to force it on you. You can turn down, oxygen if you want, or a ventilator if you want. You can turn those things down. But we're not under obligation to offer therapy because somebody's read it off the internet. That we are not under no obligation to do. And I know you guys would say the same thing in pregnancy.
Yeah, absolutely. Have that conversation with patients all the time. Doesn't matter if we're talking about the COVID vaccination or medications. It's any medication. So it's a risk-benefit discussion at all times. And we do have the shared decision-making processes that we're always involved with our pregnant mothers. But ultimately, we want to do what is best for them and for their unborn child. And so, yeah, absolutely. We're not going to cave to something that they want that could potentially be harmful or not beneficial.
Internet science doesn't.
And I would also add, just to that point, exactly, we do go through rigorous schooling, residency training, fellowship training. We have to keep up to date on the education. We learn how to understand, critique, and mostly follow evidence-based medicine.
All right, Lou is flying to Florida next week. They've got their protective glasses. They've got their N95 masks. Do they still need to be wiping everything down?
Yeah, we'll see what Hawkeye thinks. I mean, I just flew last week. I wiped stuff down. Because
I did before COVID.
Yeah, right, exactly. Because there are other germs that are out there than COVID. And I think, but, I will say that I think people have worked really hard to make flying safe. And both the airflow in planes, people masking in planes, I think that's a good idea on a long-term basis, quite frankly, because, you can spread some germs in planes, but man, the new airflow that they've worked through, airports are, when you sit and look how hard people work to keep air travel safe, I think it's a lot better than going to a bar and restaurant because everybody's masked.
I would say but I would put that down on the priority. I mean, my first priority is going to be mask. My second priority is going to be eye protection. My third priority is going to be excellent hand hygiene. And my fourth will be avoid putting my hands in my eyes, nose, or mouth. And then fifth will be wiping things down. So if you can really have that hand hygiene, that's going to be the important thing there.
Yep, right
Good.
there.
Great advice. Okay, Sharon has a question. What does early on in the disease mean?
Yeah. So I think we are referring, and what we've been referring to here on this show right now, early on in the disease, is meaning days from symptom onset. So that is going to be the most important thing. For the monoclonal antibodies and for the antiviral treatment, it really looks like you can get offered those and have benefit at up to 10 days after the symptoms started. But really for the maximal benefit, you're looking at 7 days or less from your first day of symptoms.
Lindsay wants to know, what do we know about the MU variant and other variants that are showing up in other countries today?
Hawkeye, you said this really well the other day. The Delta variant's outcompeting all the other variants, and I think there's a reason for that. They're not as deadly, they don't transmit as easily, and they're not as infectious. So I think the Mu variant's there. I think it's all about the Delta variant.
Yeah, I think we have, number one, good information from World Health Organization, which I think really stopped considering any of these other variants of concern. I think that does include Mu and Lambda. But what we have also seen, if you look at other countries' newscasts, or if you look at covariants.org, you'll see that Delta variant really, once it gets into a geographic region, does seem to outcompete everything else. So right now, I think the only thing that we are concerned about is Delta, but obviously we have a lot more sequencing data and isolates that we collect, so that is going on a global stage, so we will be aware and be able to identify new variants of concern as they do pop up. But right now, really, Delta is the one that really is outcompeting around the world.
And just to say, vaccination and monoclonal antibody therapy both work
Still
against the
works,
Delta variant.
yeah.
Looks
I
like
think-
that new pill will too.
And to that point, I think one of the nice things is the Eli Lilly product was taken off the shelf and had the EUA revoked. However, when Delta became more predominant, there still seemed to be activity from the Eli Lilly monoclonal antibody product against Delta. So that is a very good thing. So you are able to use that now in the United States.
And especially with combination.
Yeah.
Yep.
Couple more questions. Kathy wants to know, my mom is 93 with heart failure. Any disadvantages to getting the Moderna booster? You can't get that. She'd have to get Pfizer, right?
Well, that question probably
Or the
means
third
they've already
shot.
had Moderna. They probably already had Moderna.
So could they get the third shot of Moderna?
Okay, so this is the wonky answer.
Right.
You're not supposed to be getting a third booster or third shot of Moderna yet, nor should you be getting a third shot of Moderna if you've had the others yet, because we haven't had any declaration of that. Now, having said that, quite frankly, it is not hard to go out and get a booster right now. I mean, let's just be honest. People are doing that everywhere, and we know that they are, and we don't recommend it. We don't tell people to go out and get a booster unless you've been 6 months out from your second Pfizer dose and you're one of the high-risk categories, or you're over 65, then go get a booster. That's the official recommendation. But, people aren't policing the boosters.
Could it hurt, though, to get it? I mean,
So the official answer, just as I think Dr. Stites just explained it,
don't know.
excellent in the official and unofficial. The official answer is we don't have the data to understand and support. The unofficial answer is, more than likely it's safe.
Yep.
all right. Isaac has a question. Do you think that the vaccine for kids 12 and under will really make that much of a difference regarding population immunity? I saw a recent poll which found that only a third of parents are saying that they would get their kids vaccinated. So are we relying on that group of folks?
Well, we can't rely on it because not enough people are getting it vaccinated. But does it help? Absolutely, it helps. And will it help prevent older people from getting sick? Absolutely, because young kids are around old people, and as long as that statement is still true, I expect it's going to be true for a very long time, then it will absolutely help prevent the spread of disease to difficult populations. And let's just say, the Delta variant's different. And, children just had a lot more struggles with this round of COVID-19 than they did early on because they have a lot more hospitalizations. So don't get real comfortable that just because you're young, you're not going to get sick with COVID-19 with the Delta variant.
Yeah, I agree. I perfectly said. I would also add, you kind of addressed the question with the population or herd immunity, population immunity, stopping spread between the friends group, stopping spread to older people who may be more at risk. But more importantly also, is that an individual child, just as you said, we are seeing many more children affected, having to go to the hospital. Nobody wants their child infected and then affected by COVID-19, either in the acute time or the later periods where you can get that multi-system inflammatory disease, but also any long-haul COVID symptoms as well.
And I know you mentioned earlier that when moms get sick, both mom and babies can die from COVID-19. So
Yes.
that's like the worst possible outcome.
Absolutely. It's 2 deaths because of the virus. It's awful. So
And just last quick question about this new possible COVID pill. Can you compare the efficacy to monoclonal antibodies?
We can't because we haven't seen enough data yet. If you just look at what the study said, it said 50% reduction against against hospitalization, and the monoclonals are more 70 to 80%. So you'd say, well, monoclonal antibody therapy looks better, but I mean, all we have right now is a press release from Merck.
Right?
So we don't have a lot of study, we don't have the data, and we don't have a published result to where we can really all examine it and we know that it's been peer reviewed. So I don't think we really can say
Yeah,
much.
I totally agree. Again, to that point as well, it was a very small N. When we say N in the medical and scientific literature, we mean the number of people. Certainly, it was a number, 775 patients, I believe they looked at. So, small, large for some studies, just as you mentioned in your CF studies, when you get 200 people in a study, it's
That's
good.
a big study.
So it's a small study, but we would have to see what happens either in post-marketing analysis and things like that. I mean, I think it's certainly, we should have optimism about it, but again, we're definitely not going to put all of our eggs in that basket.
Not relying on it. Okay, too soon to tell. Let's get to our final thoughts, though. Heading to another weekend. Dr. Parrish, I'll start with you.
all right. As we come into the flu season, now that's another important plug to just discuss the importance of the flu vaccine in addition to the COVID vaccine, especially if you're pregnant. In our pregnant moms, your immune system is blunted. It's a natural physiologic response that occurs in pregnancy, but because of that, you're much more susceptible to becoming more severely ill, being admitted to the hospital. oftentimes, whether it's influenza or whether it's the COVID-19 Delta variant or whatever variant you may have, there's increased risk for those moms that do get admitted to have pneumonia. If you have pneumonia, that's going to affect your oxygen supply. That's going to affect oxygen to your baby. Those increase adverse outcomes for the pregnancy overall, including the worst case scenario, which would be stillbirth or a death of mom. The best way to prevent both of those situations, getting a severe infection with the flu or with the COVID-19 virus, is to get vaccinated. Unfortunately, we have great data now. Not the flu vaccine, we have decades of data in pregnancy. We know that's safe. We're getting more and more data about the COVID-19 vaccination and how safe it is in pregnancy. And even if you're still skeptical about how safe the vaccine is, you can look and see clearly that especially with this Delta variant, which is dominating the United States right now, that there's a 3-fold increased risk for stillbirth. There's a 2-fold increased risk for maternal admission to an ICU. And once you hit that ICU, nothing but bad things can happen, including death to the mom. I completely respect all of the moms out there who are wanting to protect their baby and not to put anything into their bodies that could potentially be harmful to this kiddo. Definitely respect that. But we do know with the data that we have that the vaccine is safe. So if you want to protect your baby, first protect yourself. And once you've protected yourself, you're also going to protect this baby.
Thanks for being here today. We appreciate you.
Thank you for having
Dr.
me.
Hawkinson.
So well said. I think both your guests on the desk today are really doing good.
I think so. Yeah.
He called me a guest.
Not a guest.
So, but I would second what Dr. Parrish said, but I would also, looking towards, because we did have a question about that younger age group, and I think when we can get children 11 under and vaccinated, it's going to help everybody. It will help us as a country, as a world. It will help you individually for your children. My mom is right now babysitting AJ and Josh. My sister has 3 young children who are not eligible for vaccine right now because of their age. They will be vaccinated as soon as they're able to, so we are waiting for that information. Hopefully now, if we've come into October 1st, hopefully by the end of the month we'll have more information about that and get them vaccinated. I just want to say, AJ and Josh, make sure you listen to Nana and Grandpa Dave and be good. And be good to your little sister too.
Yes, be good.
So what's the little sister? You said AJ, Josh, but she has
I
3.
think they're all under 6, so 3 of them: AJ, Josh, and Allison.
Okay, I was going to see if you could pull out that last
Yeah,
thing out of
Allison.
your hat.
Yeah.
There you go.
yeah.
She just isn't as interactive yet. She's still a little bit young.
Well, yeah, there you go. All
Well,
right.
Dr. Stites, thank you so much for being our very special guest today.
Well, thank you for
I
being a
really
special
hope
guest,
I
too.
hope that maybe one day you'll
Who's
come
got
back.
a cool cut from Hawkeye's Paris? That's pretty
I
awesome.
gotta take a dig at you as much as I can. You got a present for my mom on my birthday, so
That's a new level.
I do what I can.
All right,
You know
what you
what?
got
It's
for us?
Friday, and I'm so darn glad it's Friday. Here's what I want to say. There's a lot of noise in the world. There's a lot of noise. And when you hear a lot of noise, you're trying to figure out, what is it that I want to listen to? What's the source of truth? What's the thing that's going to make the most sense to me? Is it going to be internet science? Or is it going to be people who have studied the virus and viral disease their entire lives and have worked on developing vaccinations to improve the lives of millions and billions of people around the world their entire lives? So do you want to hear the noise or do you want to hear the truth? And what I ask you to do is help us find the truth, because when you do that, when you actually look for what is true in the world, you'll come down to see that those who are trying and have spent their entire lives at working to keep people safe don't have some crazy ulterior motive that is guiding them to do terrible, bad things to people. Instead, those of us who spent our entire professional careers dedicated to keeping people safe and alive are doing that right now, every moment of every day, and we know how to do it. You follow the rules of infection control. They travel with you wherever you go. You get vaccinated against this terrible disease, this terrible pandemic, and you help us end the reign of COVID. We can end the reign of COVID, but we have to quit listening to internet science and listen to the people who have spent their entire lives doing nothing but working in this area and trying to help the lives of billions of people. That's what the thing is to do. And then we can all live long and prosper.
You are definitely coming back.
Maybe someday. Maybe someday.
I mean, that is all right. Have a great weekend. And we really appreciate all three of our doctors today. And thank you for being with us. So coming up on Monday, we're going to be talking about second opinions and where you get those second opinions. We're joined by breast surgical oncologist, Dr. Jamie Wagner. And we're going to hear from a patient who received a second opinion here, and it changed her diagnosis, her treatment, and ultimately her outcome. So have a great weekend. We'll be back with you here at Monday at 8 o'clock.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.